Hello, everyone, and welcome to San Antonio Breast Cancer Conference Symposium, Molecular Tumor Board. I'm Pedram Razavi from Memorial Sloan Kettering Cancer Center. I'm a breast oncologist, and I will be moderating this session, and I'm joined by a fantastic group of panelists to discuss the cases with you, and I will introduce them later on. So with that, let's move on to the session. We have 60 minutes and multiple cases to discuss, so don't want to waste any time. So these are our disclosures. So the modern landscape of precision oncology, as all of us are aware, have changed very recently. We are using targeted therapies and precision oncology very routinely in clinic. And one big part of this precision oncology is identifying the targets using molecular assays and genomics. And we use them very routinely in clinic. Of course, on top of that, we also try to move the field forward with doing liquid biopsies pre and post-treatment, samples pre and post-treatment, understand the biology of disease better, understand the subgroup of patients who respond or do not respond to certain therapies to improve the outcomes. And then all of that will be hopefully translated back to clinic in terms of trials. And we've been using these type of genomic efforts since 2013-14 very routinely. And we started using them more in clinic, the knowledge gap between what was known and what is unknown started to increase. There are alterations in genes, well-known drivers in cancer that we didn't know or we don't know how they behave, and are they drivers, are they pathogenic alterations, oncogenic alterations or not. And there are also alterations in rare variants that we were not aware of, or rare genes that were not routinely seen on that type of cancer. So as these type of gaps started to grow, there was an absolute need to close this gap, and there is multiple efforts to develop these knowledge-based toolkits to help with precision oncology and curate these mutations and genes in a programmatic manner. And one of them that I would like to highlight developed at MSK is the OncoKB that assigns, it's the manually curated database of genes and alterations in a disease-based manner, and gives the genes and the mutations a level of evidence, and that level of evidence can help the oncologists and the physicians in clinic to navigate this genomic data much better. But there is a gap still. There is much more interaction between genes, between the pathways. The genomic alterations, the tumor doesn't have only one driver. The tumor often has multiple drivers. They are sometimes working together, sometimes bypassing them. There's some interactions with them. And that complicates the interpretation of these results more and more. And as we started sequencing and using genomic panel with these next-gen sequencing panels that use a wide range of genes, these type of interactions become even more significant. And it's not fair to ask an oncologist in clinic to be able to interpret all of these results when they're busy seeing patients. And on top of that, the cancer evolves and changes very routinely. So there is a significant amount of spatial heterogeneity in the tumor, especially in breast cancer, as all of us are aware. And also there is temporal heterogeneity and evolution because of the bottlenecks that we impose with our treatments or because of the cancer itself, and that also complicates the results even more, to the point that, when we have liquid biopsies, we have tumor, and also we have multiple tumor samples from a patient, interpreting these results need expertise. And putting all of this together, unfortunately, there has been a disconnect between what we have in our guidelines that we are referring to guide us through clinic, and ever-growing list of genes and alterations that we see in these reports. And again, it's not fair to put all of this on the shoulder of busy physicians to be able to interpret this. So we thought, we saw the need at MSK a few years ago, and multiple other centers have done this the same. And considering our volume, we started having this breast molecular tumor board that we started in February of 2020. And there's a group of breast oncologists, pathologists, radiologists, radiation oncologists, and also translational scientists, genomic experts. All of us is sitting together, as well as breast fellows to train the next generation of molecularly focused physicians and experts. And then we review the cases very routinely in clinic. But what is important for such molecular tumor board is the multidisciplinary nature of these. It's impossible to interpret the molecular data in an isolated manner. We need to have input from different aspects and different disciplines to help understand this and put them in the context. So we have also input from the pathologists and molecular pathologists and also radiologists, in addition to all the other providers. And also in addition to that, we do higher levels of genomic analyses to better understand these results. So with that, we would like to do a molecular tumor board this year at San Antonio that somehow mimics that multidisciplinary nature. So I would like to introduce our panelists. So from medical oncology, we have Dr. Joyce O'Shaughnessy from Baylor. We have Dr. Nick Turner from Royal Medicine Hospital, Institute of Cancer Research, UK. We have Dr. Giuseppe Curigliano from European Institute of Oncology, Milano. And we have Dr. Nancy Lin from Dana-Farber Cancer Institute. Dr. Gaorav Gupta is a radiation oncology expert. For breast radiology, we have Dr. Sarah Eskreis-Winkler from MSK. And for surgical and molecular pathology, we have Dr. Maryam Shirazi from Tempest Lab. So without further ado, we're going to go to the cases. So case number one. This is an 80-year-old woman with multiple comorbidities with initial diagnosis of ER-positive, HER2-negative disease, diagnosed in 2019, who was now recently diagnosed with a metastatic triple-negative breast cancer. So the diagnosis goes back to 2019. She had a left lumpectomy. She had a multifocal, well-differentiated invasive ductal carcinoma. The tumor was strongly ER-positive, PR-negative, HER2-negative, and she didn't have a lymph node staging as appropriate for the age, and RT was omitted. She received adjuvant AI since then, and in August of 2022, she was presented with a rapidly growing left breast mass. Ultrasound showed a lesion that was 2.6 by 2 centimeter. There was a core biopsy of it that showed a poorly differentiated invasive carcinoma. The tumor was ER negative, PR negative, and HER2 negative, and also AR negative. No DCIS or benign tissue was seen in the background. She had a PET scan that showed multilobar mass in the breast, but it also showed a right upper lobe lung lesion with possible pleural involvement and multiple hilar adenopathy, FDG-avid, that were all consistent with metastatic disease. So she established care at MSK at the time, and when she was seen in the clinic, she was noted to have even more growth of the disease. At the time, the tumor was more than 4 or 5 centimeters, with evidence that is involving the skin as well. And she declined the biopsy for the health reasons. So I just want to highlight some of the comorbidities that she had. She had a CVA ×2, she had 2 strokes, she had a hip fracture, she had coronary artery disease and stent placed, she has cardiac issues, pacemakers, arrhythmia, AFib, and anticoagulation. So multiple comorbidities in the family. So with that, we start with radiology.
So on the left, we have CC and MLO mammographic views. The red arrow is depicting an irregular dense mass in the upper inner quadrant posterior depth. And on the right, we have the sonographic correlate, an irregular mass with heterogeneous echo texture. Next slide. Thanks. So in August, she had a PET CT to look at the extent of disease. And if we start at the top right, we see in the left breast an FDG-avid mass. Going to the top left, the yellow arrow is showing an FDG-avid perihilar node. Then right below that, the blue arrow is showing a mildly FDG-avid axillary lymph node. And in the bottom right, the yellow arrow shows a pleural-based pulmonary nodule, which is FDG-avid and highly suspicious as well.
Dr. Shirazi.
Sure. So on the top, we have the morphology of the left breast from 2019. So this is a well-differentiated lesion. You see there is gland formation, all the tubular structures with the lumen in the middle. These are neoplastic glands. They are highly infiltrative, angulated. So this was a well-differentiated invasive ductal carcinoma, strongly positive for ER and negative for PR and HER2. On the bottom, we have the more recent lesion from also left breast from 2022. Just the overview of the H&E pictures, they don't look like each other. So the lesion on the bottom, this doesn't have glandular architecture. This is a high-grade lesion. Cells are larger, more polymorphic. So when we see a lesion like this, for the most part, we try to approach it with an open mind. So this could be another primary. This could be even a lesion not coming from breast. And I think based on the panel of immunostains they performed, this lesion was positive for CK7 and SOX10, negative for GATA3. So this is a combination that pretty much could be, and also ER, PR, HER2 negative. So this combination is actually good enough for a metastatic breast cancer triple negative.
Thank you. And in your opinion, these two tumors are morphologically dissimilar, correct? Oh. I was asking if these, I have a hard time hearing you, and you have a hard time hearing us.
Yes, correct.
So how should we do this? So in your opinion, these are two different tumors morphologically dissimilar?
They don't look like each other,
Yeah,
yes.
very good. So standard of care options and additional tests, what we're going to do. So Dr. O'Shaughnessy, what do you think? This is a newly diagnosed metastatic triple-negative breast cancer. How should we move forward?
I suppose the question is, no DCIS was found on a biopsy. Could this be metastasis from elsewhere? It doesn't look like it on the PET CT scan, not another primary per se. It looks phenotypically consistent with metastatic triple-negative breast cancer, but they're so disparate, it's so unusual. Certainly we need the PD-L1 status as has been ordered. We also need germline BRCA status panel testing. Would be nice to know the germline PALB2 as well. And so, yeah, those, otherwise we just need all the information we can get, but it would be nice to know if this really truly is a breast cancer.
Fantastic. So, Dr. Lin, while waiting for the results, we have a patient with rapidly progressing triple-negative breast cancer. What do you think of the standard of care options for this elderly lady, multiple comorbidities?
Yeah, so if we were not to consider, first just if we were to imagine somebody who is not elderly and fragile, what would we think about for first-line therapy for metastatic triple-negative breast cancer? Typically we would start with PD-L1 status. If the patient has PD-L1 positive cancer, they would receive chemotherapy with pembrolizumab, and if PD-L1 positive, could receive single-agent chemotherapy, with the exception that if somebody has a germline BRCA1 or 2 alteration, or perhaps PALB2 germline alteration, one might consider a PARP inhibitor instead of chemotherapy. Of course, in this person, we have to consider that she has quite a number of comorbidities. We didn't hear her performance status, but she's had 2 strokes, she has cardiac disease, and I think one of the values of the additional testing, which I think we'll go through in the rest of this case, is to identify whether there are additional targets that we could consider that would allow us to de-escalate or give her an option for less toxic therapy, particularly if she has PD-L1 positive cancer, where we would normally be giving cytotoxic chemotherapy, or if she's BRCA1 or 2 negative, where we again normally would be giving some sort of cytotoxic chemotherapy.
Fantastic. So the patient had a liquid biopsy. It was resulted 7 days after the patient was seen in clinic, and it showed 52 mutations with a tumor mutational burden of 250, and MSI high was detected. Multiple alterations that we know that are relevant in breast cancer were seen here, but the tumor had many, many mutations. Let's just first talk about TMB. Dr. Turner, what are your thoughts on assessing the TMB and MSI on ctDNA?
Yes, there's 2 aspects here that are both really quite uncommon in breast cancer, but important. So most importantly, she's got microsatellite instability, and this can be measured very robustly in ctDNA and is a strong indication for the pan-tumor type indication for pembrolizumab. And this is one of the causes of high TMB. This is a very unusually high TMB for breast cancer and, well, pan-tumor. What's much more common is finding a TMB that's just slightly higher than the cutoff for pembrolizumab, which is 10 or higher mutations per megabase. And that can't really be assessed very reliably in circulating tumor DNA, because we have multiple reasons that can elevate the TMB in ctDNA. So mutations can come from clonal hematopoiesis that you have in circulating tumor DNA assays, and also lots of subclonal mutations you can pick up in liquid biopsies, all of which can elevate the TMB. So if you see a TMB that's, just above 10, that's uncertain, really, whether that's an indication for pembrolizumab on that individual pan-tumor indication. And that really needs to trigger getting tissue testing. But for this individual patient, she's got MSI high, which is a relatively strong indication to consider that pan-tumor indication of pembrolizumab.
Fantastic.
So
Yeah, so
I would like to do a comment, because pragmatically, in Europe, in order to prescribe pembrolizumab for an high tumor mutational burden, you need also assessment of PD-L1 on the primary tumor or in the metastatic disease.
Yeah.
So in this specific case, since there is no previous exposure to any chemotherapy, the disease-free interval was 3 years, I believe on liquid biopsy, tumor mutational burden can be reliable in order to prescribe pembro. But I would like also to know if the tumor is PD-L1 positive in order to prescribe in my country the indication to immunotherapy. And immunotherapy per se in an 80 years old should not be considered a contraindication. Because I know in the audience how many of you have elderly patients receiving immunotherapy. Yep. This is an important question.
Absolutely. So this is an astronomical high TMB, and we actually confirmed this in the tumor as well. And there was a question also that was brought up about the relatedness of this tumor. So we sequenced both the triple-negative breast cancer and also the historic primary tumor. And this is the primary tumor from 2019, and these are the mutations. There were multiple pages of alterations here. But what was very clear, that there was no mutations shared between these two tumors, again highlighting that this is a new primary that the patient developed, has no relatedness genomically with the previous one. The germline testing also showed it was negative, and the tumor had a significant high TMB. Just for those who don't have a reference here, usually the TMB in breast cancer is around 2 to 3 mutations per megabasis. This is extremely high for breast cancer, and the MSI high score was more than 30 as well here. So this is the copy number profile. These are the chromosomes, and for a heterozygous or normal cell, you're going to see a line in the middle, and you see that there were multiple alterations and copy number changes in this triple-negative breast cancer. This is a relatively low purity tumor, but you see that there are no common copy number changes comparing these two, again confirming that these two tumors are not the same, and this is a completely distinct tumor. So after that, we performed MSI score, showed an MSI score of 25. Usually in breast cancer, the approval, FDA approval, is for MSI score of more than 10. Here at MSK, we did a validation study, and we looked at the MSI scores in breast cancer, anywhere between 3 to 10. We call them indeterminate, and we do additional testing in those patients, but this is an unequivocally high MSI score. We also performed signature analysis, and the signature analysis showed a very dominant MSI MMR signature in this tumor. Further staining was done. So Dr. Shirazi, what do we see here?
Yeah, so the IHC also confirms all of these findings. So we have the picture of MLH1, PMS2, IHC, one of them, they both look the same. And all the blue you see, these are neoplastic cells that are not expressing MLH1 or PMS2. And then on the bottom, that's a great contrast. You see that the neoplastic cells, they are all expressing MSH2 and MSH6. So this is consistent with an MMR deficient tumor with loss of MLH1 and PMS2.
So there's a case of somatic MSI high tumor. And these are the PD-L1 staining.
Sure. And there's a PD-L1 SP263, which is also, it has a CPS of more than 10, I guess this was interpreted as that such.
So this is the perfect molecular storm to prescribe an immunotherapy. Microsatellite instability, high tumor mutational burden, and PD-L1. So unless you invented the case, I never saw a case like this.
Yep. This could be the Luis Diaz's story again in New York Times. So, so let's talk about hypermutated breast cancer. What are the reasons for hypermutation in breast cancer? Dr. Gupta, what are your thoughts?
I mean, you know, there are different etiologies of hypermutation. I think in breast cancer overall, the prevalence is relatively lower, but you know, as we saw here, MSI instability does occur and should be checked for in metastatic patients. You can also see pol epsilon mutations that can sometimes contribute, and another emerging mechanism that I think is important in breast cancer is APOBEC mutagenesis, which you know, we're still understanding when and how to identify it best, but I think could be relevant in immunotherapy response.
Dr. Shirazi, so just to expand on that, we know about APOBEC. What is the significance of APOBEC? What is the difference between APOBEC and MSI signatures as hypermutated phenotype? What else we see here?
Sure. So generally speaking, these are the major drivers of hypermutation in breast cancer. Dominant APOBEC mutational signature in about 60% of these hypermutated cancers. So this is a very important signature in breast cancer in general and enriched in these lesions. Also mismatch repair deficiency, and to a lesser extent, poly mutated signature is also associated with hypermutation. I don't know if I should comment on the, okay.
So the clinical indication, we know that there is a FDA approval for single agent pembrolizumab in this setting for in a TMB high and also for MSI high. So just update you on the case. She received a single dose of pembrolizumab in end of November of 2022. She developed actually, unfortunately, immune-related adverse events. She had hypothyroidism, required admission to the hospital because of worsening of her AFib. And then after that, she came out of the hospital and she refused to come to clinic and said, I don't have any disease anymore. So got to the point that she finally came to clinic, and she had no palpable disease in the breast. She was not interested in further imaging, and she comes occasionally to clinic for visits with no evidence of disease. We haven't had a chance to convince her to get a PET scan yet, so hopefully that will happen. But we were able to convince her to get an ultrasound when she came for a visit in January, and this is what we see from the January of 23.
Yeah, so here's the imaging evidence here. We have in August 2022 that irregular mass, and by January 2023, there's near complete resolution of the mass. It's very hard to see on ultrasound if it's even there at all. Fantastic.
So again, highlighting that even in an 80-year-old, doing genomic testing can completely change the therapeutic landscape for that patient, and this is a good example of it. It's extremely rare to see such a high MSI in breast cancer, but that one case worth doing the analysis. So let's just go to case number 2. So this is a 49-year-old woman with ER-positive, HER2-negative metastatic breast cancer and a rapidly progressive disease on the first-line CDK4/6 inhibitor plus AI. So the history goes back to 2022 when she was diagnosed with locally advanced breast cancer. It was moderately differentiated lobular carcinoma, 9 centimeter, multiple axillary nodes, strongly ER/PR positive, HER2 negative. She had a PET scan that showed the primary breast and axillary disease, but no disease outside. There were some sub-centimeter bilateral lung nodules that were considered to be nonspecific. She received neoadjuvant dose-dense ACT, followed by left mastectomy and sentinel lymph node biopsy that showed extensive amount of residual disease, T3N1A, 7.5 centimeter, but relatively good response in the lymph nodes, 1 out of 2 lymph nodes, clear margins. The disease was ER/PR positive and HER2 negative. She completed post-mastectomy radiation therapy, followed by OSAI, and she had a BSO and oophorectomy, and the ovarian suppression was dropped. She asked for delay in starting abemaciclib per monarchy as she wanted to undergo bariatric surgery, and she started it in May of 2022. She had a routine CT scan at the time that actually accidentally she was found to have metastatic disease with bone mets. She had a T10 bone biopsy that showed ER 20%, ER negative, HER2 negative breast disease. This tumor underwent sequencing. And unfortunately, relatively quickly after, in December of 2022, she had progression of disease in the bone. So imaging?
Sure. So these are T1 weighted images, MRI images of the spine. On the left, the sagittal view shows extensive osseous metastases. On the right, I'm showing an axial slice through the T6 vertebral body where you see some of the osseous mets, and there's also posterior mass effect causing compression of the spinal cord.
So on the left side, we have the specimen left breast mastectomy. So the lesion, these are just neoplastic cells, very discohesive, the classic single filing we see in invasive lobular carcinomas of breast. This is positive for ER, PR, negative for HER2. Ecaterin also shows loss of expression, which is consistent with invasive lobular carcinoma. So the size of this lesion is 75 millimeters. 1 out of 2 evaluated lymph nodes positive, YPT3 and 1A. And then on the right side, this is the MET from T10, which pretty much morphologically looks the same as the primary lesion, and this one's ER positive, 20%, and PR HER2 negative.
So the patient underwent some additional workup, tumor sequencing was going. So what are we thinking about next line treatments, Dr. O'Shaughnessy? So it's a patient with rapidly progressive disease on first line treatment.
Well, we just heard this morning from Antonio Lombard Cusack from the Parsifal trial how poorly patients do if they don't get 1 year at least of progression-free survival from CDK4/6 inhibitors first line. The median survival was like about 1.5 years. So it's a poor prognosis, and we really need circulating tumor DNA to see what targets there are. A question is whether we should even go with another line of endocrine therapy. And we'll hear at this meeting about potential use of even inavolisib for patients if she has a PIK3CA mutation, or alpelisib, and alpelisib not approved yet, but coming, and then the alpelisib would be an option for her. An ESR1 mutation might be another option for the patient, although the data are strongest if patients had at least 1 year of their first-line CDK4/6 inhibitor, so perhaps not the best option for her. This is another patient you want you want TMB, you want MSI, you certainly want germline status as well for her to see if she's a candidate for a PARP inhibitor. But this is a patient you really want to know her performance status, what does she have in the way of symptoms, et cetera. This is a patient that outside of a trial that could also be considered for chemotherapy, such as capecitabine. So this is somebody where the genomic evaluation will be very important for her.
So tumor sequencing was done on the primary tumor and also bone biopsy. The tumors were related, they share multiple mutations. And what stood up at the very top is a BRAF V600E mutation. It's completely uncommon in breast cancer to have BRAF alterations, especially V600E. So this tumor had a clonal BRAF V600E mutation, also had a BRCA2 deep deletion. Germline testing was done, didn't show any germline variants. I'm showing here just the copy number data again. You see a deep deletion of the BRCA2 here. The tumor also had MYC amplification. Further look into the BRCA2, actually she ended up having a large intragenic deletion of one allele in BRCA2 and a loss of heterozygosity of the other allele, resulting in complete homozygous deletion of BRCA2. So all the exonic regions of the majority of exonic regions of the BRCA2 were lost. So this is a tumor with somatic BRCA2 mutation. So, Dr. Turner, do you think, based on this genomic data that we have, can we explain such a short disease-free survival and also progression-free survival for this patient?
Well, I think that, well, you've just shown us there's two potential reasons she could have done poorly. So we know that that mutations that activate the MAP kinase pathway are a mechanism of resistance to endocrine therapy. And although the BRAF V600E mutation is incredibly rare in primary breast cancer, it can be selected as a mechanism of endocrine resistance. So, and they are definitely more frequently found, although still uncommon, in metastatic breast cancer. So that could be one reason that a tumor has acquired a V600E mutation in BRAF. Also, there's data that's largely come from your lab that tumors that have lost BRCA2 are also potentially more likely to be able to acquire resistance to CDK4/6 inhibitors because BRCA2 and RB1 are really close on the genome. So if you've lost BRCA2, it's also easier, if you like, for the tumor to lose RB1. And we know that tumors that have lost RB1 are completely resistant to CDK4/6 inhibitors.
So just to recapitulate, this is the data that was referring to, we know that these MAPK alterations overall, they're not as uncommon. There are 13% of the breast cancers in the endocrine resistance setting can have MAPK alterations. BRAF obviously is a big-time activator. We saw it only in the endocrine-resistant disease in around 0.6% of the cases. NF1 loss is a much more common alteration and often is acquired in this setting. I'm sure that giving the patients MEK or ERK inhibitor can improve the outcomes and resensitize the cells to endocrine therapy. There's data on the fulvestrant. And Dr. Turner actually did a study looking at the NF1 loss and MAPK alterations in CDK4/6, but specifically for NF1 loss, what are your thoughts?
Oh, we saw some really interesting data today, of course, in the general session about the association of NF1 mutations with resistance to endocrine therapy, but potentially making them sensitive to CDK4/6 inhibition. That's different, though, to BRAF.
Yeah. So there is also much more data coming on how some of these activators of MAPK can actually result in resistance to CDK4/6 inhibitors. So this is the work from Hee-Won Yang lab, looking at MYC. This patient already had MYC amplification, but also some of them result in stabilization of MYC and resistance to CDK4/6 inhibitors. And as Dr. Turner mentioned, BRCA2 loss, also an HRD, seems to be a resistance mechanism to CDK4/6 inhibitor through the work that has been done with our group and others. So let's talk about BRAF V600E. Dr. Turner, Dr. Lin, what are your thoughts?
Yeah, I mean, before I get into the specific question, I think it was particularly important in this case to have the sequencing actually on the primary tumor, just to be sure that there is clonal sharing between the primary and the MET. Otherwise, BRAF alterations are so uncommon in breast cancer, you'd be wanting to look to make sure she's going to have not a occult melanoma or colon cancer. But certainly through BRAF signaling, you can get constitutive activation of MAP kinase signaling. And if we look across other solid tumors, against the data in breast cancer is very limited just because the number of patients who have this alteration is so limited. This did lead to a tissue agnostic FDA approval with very respectable response rates to the inhibitor.
Dr. Curigliano.
It's rare, but it's there. So
it's
also
rare,
in the
but it's there.
Aurora trial, I remember 1%
Yes.
of patients harboring BRAF
And I think this-
V600E was there. Yeah. So of course here we have an off-label agnostic potential for this patient.
And I think it raises question, you raised this as well, is what level of evidence do we require based on the rarity of an alteration, right? There's never be a phase 3 trial in breast cancer. There'll not even be a phase 2 trial that's powered properly. So I think it is an interesting question to ponder when you see these rare alterations that have tissue agnostic approvals, or even if there's not an approval, that you see substantial pan-tumor activity, maybe not always in breast cancer.
So, Dr. Curigliano, would you add endocrine therapy to this patient if the patient receives?
It was 20% the expression of estrogen receptor. So since here we are going completely off label, of course, you may consider eventually the combination of the dabrafenib, trametinib, and fulvestrant without any level of evidence and any grade of recommendation. Now let we see the selection you did.
And there's also the data on the feedback between MAPK pathway and ERK and increase in activity of the estrogen pathway. So we thought it was reasonable. We actually at the time had a trial of MEK inhibitor plus fulvestrant at MSK that Dr. Rosen was running. But we thought that probably dual inhibition with MEK inhibitor based on the FDA approval would be a better option for this patient, and we added fulvestrant to the treatment for the patients based on the molecular tumor board recommendation. And this is the data that I'm showing for the patients. Is just a biomarker, tumor markers that showed a very significant drop for a patient who had just few months on first-line CDK4/6 had a fantastic response to MEK inhibition plus fulvestrant. The question is, if the patient starts to have some progression at this point, and the patient had a BRCA2 mutation, what should we do? Dr. Gupta.
Well, so this patient did not have a germline mutation, so it doesn't fit the FDA approval for metastatic use of PARP inhibitors, but there is some data, and it's listed here, the TBCRC 048 trial that evaluated response to olaparib in patients with somatic BRCA1 and 2 mutations, and the deep deletion involving most of the exons of BRCA2 would definitely fall into this category. And they observed response rates of 50%, and there are also other case series looking at similar populations with similar response rates. So I do think, as indicated here, I think in the NCCN guidelines, that somatic BRCA1 and 2 is an indication to consider olaparib in the metastatic setting.
Fantastic. And there is also some data based on prostate and ovarian that for these patients who have deep deletions, there might be even better responses to PARP inhibitors, as the mechanism of resistance often is reversion mutations, but these don't have any way to reverse that. So hopefully if the patient has progression at the time of progression, this patient can receive PARP inhibitors as well. So let's move to the third case. This is a 85-year-old healthy woman with a history of early stage breast cancer and recently diagnosed metastatic high-grade neuroendocrine carcinoma of pancreatic origin. And bear with us, it's not pancreatic cancer. So primary breast cancer, so the diagnosis goes back to 2016 when she had a right lumpectomy with sentinel lymph node biopsy, showed a low-grade the IADC. The tumor was ER 90%, PR 60%, HER2 negative. The patient received radiation therapy followed by an anastrozole for 5 years. In 2022, December, she had a chest CT for other reasons and was found to have large liver mass and a pancreatic mass and multiple peripancreatic masses and lymph nodes, highly suspicious for metastatic disease of the pancreatic origin. There was an MRI of the abdomen done at the time that showed a pancreatic body mass measuring approximately 4 centimeter, multiple peripancreatic and portocaval and retroperitoneal lymph nodes, liver mass spanning around 10 centimeter in the liver. She had an initial consultation with the GI oncology at MSK and outside MSK actually at this point. She was found to have hyponatremia with a sodium of 114 that's thought to be a paraneoplastic syndrome because of SIADH and neuroendocrine disease potentially. She had actually a biopsy of the disease at the time of the liver that showed metastatic poorly differentiated neuroendocrine carcinoma. It was a non-small cell type and thought to be pancreatic origin with a P67 of more than 90%. She established care at MSK at the time, received first-line carboplatin etoposide with resolution of SIADH, and then she had a scan in May of 23 that showed a mixed response, some good response in the liver, pancreas, and abdomen, but there was an increase in the axillary adenopathy. So let's review the imaging.
So here's the CT scan shortly after she began the treatment. Starting in the top left, there's a large right axillary mass, which is extending to the skin surface, and then deep, it's involving one of the ribs. Top middle, we're seeing a pulmonary nodule along the fissure, the minor fissure of the left lung. And then on the top right, there's some thoracic adenopathy, so right perihilar and subcarinal. Going to the bottom left, we see some periportal lymphadenopathy, and then bottom middle, there's a mass in the liver. And then finally, the bottom right, we see osseous metastases involving the sternum and the anterior ribs.
So this is the biopsy from the liver lesion, and this is a very high-grade lesion. So these nuclei are very large, they are very polymorphic. So like the first case, when we see a lesion like this really could come from anywhere. And we need to keep an open mind, we need to do a complete workup. So here, some workup was done, and I think this morphology, not knowing what the primary tumor could be, it could be also consistent with a neuroendocrine neoplasm, and I think that prompted pathology to do the neuroendocrine markers, as you see on the bottom. So synaptophysin was strongly positive, the same for CD56. These two are the neuroendocrine markers. And then Ki67 shows these highly proliferative nuclei, and it was at 90%. So based on this morphology, based on this immuno profile and the location of the tumor and the frequency of neuroendocrine neoplasms in different parts of the body, the diagnosis was a metastatic poorly differentiated neuroendocrine carcinoma, non-small cell type from pancreas origin.
So the patient had actually a sequencing of that liver metastases and a lot of surprise findings. First of all, the patient had multiple alterations that we often see in breast cancer, PIK3CA mutations, but also had PTEN loss of function mutations, had a P53 loss of function mutation, and also an RP1 deep deletion. But what was very surprising was this ESR1 D538G mutation in a pancreatic neuroendocrine tumor that actually raised the flag, and that was the reason this patient was referred to molecular tumor board, why this tumor has a ESR1 mutation. Tumor had a high TMB with a TMB of 21.4 mutation per megabases. It was not MSI high. And further analysis that I'm not showing here showed a loss of heterozygosity of P53 and P10, telling us that there was a biallelic loss and complete loss of P10 and RP1 and P53 in this tumor, and also there was a complete loss of RB. So does this genomic profile, is it consistent with a neuroendocrine tumor? Dr. Curigliano?
Here you have two primary tumors, according to the pathologist, and you have a mixed response after carboplatin and etoposide. So here you should consider if the mixed response is related potentially to different tumors, and so you may consider to add something to treat the endocrine responsive disease. It's a very complex case, I believe, and NGS here is suggesting that maybe you may have also clones coming from breast cancer.
So we looked at our data to see how often we see actually 538G in non-breast cancers, and this is the data from more than 100,000 breast tumors from the C-bipolar MSK Impact series, and obviously majority of the cases are breast cancer, endometrial cancer, the cancers that you expect to have these type of alterations, but neuroendocrine tumor was not one of them. We did a signature analysis, the tumor had a clear ApoBec signature, and then we used the algorithm that was developed at MSK by Dr. Berger's group, that looking at the tumor type predictor. And by running that algorithm, this is a model that was trained on multiple cancer types and looking at the genomic alterations, copy number changes, so on and so forth, and predicts the type of cancer. And it gave a very high likelihood of breast cancer, 77%. And that prompted us to look into this case a little bit more all of this information together. So for further workup, we requested the pathology material from outside to actually perform ER/PR HER2 staining on that liver biopsy, something that was not done. They thought it's a GI tumor, so they didn't do any of her standard staining. We requested a material from 2016 to see if this is actually related to that tumor or not. We also recommended to have a biopsy of that mixed tumor, as Dr. Curigliano just mentioned. There was a discordant response, so we thought it's reasonable to get that sample. So actually, the biopsy of the right axilla was performed. What do we see, Dr. Shirazi?
Yes. So I think to just put it in one sentence, they don't look like each other. So this is the most important part here. So we established the diagnosis of a neuroendocrine carcinoma in the liver biopsy, and now we have a right axilla biopsy that looks like an invasive ductal carcinoma, and it's strongly expressed in GATA3. It's positive for ER, PR, negative for HER2. So this looks like an invasive ductal carcinoma and very different from liver lesion.
So the patient appears to have metastatic disease as well. The question was, are these two tumors related or not? And before that, let's just talk a little bit, relatively shortly, on neuroendocrine transformation in breast cancer. What do we know about neuroendocrine transformation in breast cancer? Dr. Shirazi.
Yeah, so I guess whenever we want to associate a neuroendocrine type of neoplasm to breast, whether the lesion is in breast or we think this is a primary breast, then we need to consider several things. One of them is maybe this is really a primary neuroendocrine breast cancer, very uncommon. However, and we make that distinction based on the morphology and the expression of the neuroendocrine markers. So if more than 90% expression of neuroendocrine marker, if the morphology is telling for a neuroendocrine neoplasm, then that is a primary neuroendocrine neoplasm divided into low-grade neuroendocrine tumor, high-grade neuroendocrine carcinoma based on nuclear grade. Majority of these lesions, however, they are mixed. So we have 10 to 90% neuroendocrine marker expressions and a mixed type of morphology, or a morphology that's totally like a breast cancer, and then we have lesions with less than 10% expression of neuroendocrine markers, and these are basically invasive breast cancer. More importantly, because we have such a low prevalence of the primary neuroendocrine tumors in breast, we also need to think about MET. And then there is this third category that is not well described in breast cancer. However, we have it in lung cancer and prostate, in some other cancer types, that we could have a neuroendocrine histological transformation, where a tumor that's one type of tumor changes to a more aggressive type of tumor and undergoes a neuroendocrine transformation due to the pressure of the therapy. And this is basically some sort of accord resistance mechanism. In terms of the molecular alteration, these lesions usually are a mix of the primary tumor and also alterations occurred during neuroendocrine transformation.
So we got the primary tumor from 2016, and we were able to biopsy the liver. Unfortunately, the pathology material from 2023, the axilla, was not enough for sequencing. But what was very striking was that these mutations shared alterations, rare alterations. There was a PIK3CA mutation that was common between the primary tumor and also this liver metastases. Very surprisingly, ESR1 mutation was also seen in the treatment-naive primary tumor. PTEN loss was also seen in both of the tumors. But RB1 loss and P53 were all new in this neuroendocrine transformed tumor. So based on, we did the analysis, and the likelihood of these tumors being related was more than 99.99%, probably 10 more zeros. And then, these two tumors are the same, and this is a neuroendocrine transformation. So let's just relatively quickly talk about some of the alterations that we see here in this patient and what are the clinical relevance of them. So the tumor obviously has ESR1 mutations. All of us are familiar with ESR1 mutations, but it was surprising to see ESR1 mutation in the primary tumor. Dr. Turner, what are your thoughts on that?
Oh, it is unusual, but it's certainly not unheard of to see activating mutations in ESR1. They're present in about 1% of primary ER-positive tumors.
And the patient also has a PIK3CA mutation, and consistent with the APOPEC signature, we know these 545, 542 codomain mutations are more common in the APOPEC. There was a PTEN loss. Dr. Lin, what are your thoughts on the PTEN loss in this patient?
Sure, I mean, you can definitely see PTEN loss in breast cancer. The PIK3CA obviously is relatively common in ER-positive, HER2-negative breast cancer, and all of these, whether the the PIK3CA mutation or the PTEN loss, would allow for potential selection of capivasertib in the case of PTEN loss, and then for PIK3CA, either capiva or alpelisib. So this does offer her some additional options in the future. It's interesting to speculate whether this would work both against the liver, kind of more neuroendocrine appearing tumor, and the more sort of typical breast cancer appearing axillary mass.
So P53 and RB1 loss, these are acquired. We know that this combination in prostate cancer in the thoracic oncology are associated with neuroendocrine transformation. In this case, very clearly seems like these are the markers, Dr.
So are
Curigliano.
markers of a resistance to CDK4/6 inhibitors, a resistance to PI3 kinase inhibitors, and potential resistance also to endocrine therapy.
So, Dr. Curigliano, now that you have the microphone,
So you can
what are
give,
your thoughts?
You may add pembrolizumab eventually to the standard chemotherapy that she is receiving, or you can give an antibody drug conjugated in a clinical trial.
Dr. O'Shaughnessy.
Yeah, I think we're still waiting on her HER2 status, see if she's HER2 low. If we can find a HER2 low anywhere among these biopsies, I think antibody drug conjugate would be great for her. I think the idea of using pembrolizumab would be great. I would be inclined to give her chemotherapy and would choose one of the regimens. She's just recently had platinum, so we would go with a taxane and pembrolizumab for her. But I would be intrigued by the antibody drug conjugate if she's HER2 low.
Fantastic point. So, Dr. Turner, or anyone else here, would you give the patient, if we get the biopsy of the liver and it turns out to be ER positive, would you offer the patient CDK4/6 inhibitor with this genomic profile?
We've actually had a number of debates about this as we've been putting together our SPORE grant related to, I think, very strong feelings that RB loss is going to prevent activity of CDK4/6 inhibitors, and is it actually ethical to purposely put somebody on a study of a CDK4/6 inhibitor, or standard of care for that matter, who you know has a deep RB loss? And I mean, I think that's a very valid question because mechanistically, it would not be expected to work. We have clinical data, albeit retrospective, that indicates that these agents are less effective. And given the sort of aggressiveness of her disease, particularly in her liver, and then even her axillary disease, which is more typical of breast cancer, has progressed through her first-line therapy, I would agree that I would stay away from endocrine therapy. CDK4/6 is the next line of therapy.
And obviously, capivasertib just approved. Dr. Turner, if this is ER positive, would you offer the patient
Yeah, I mean, that's definitely an option for, because we know that capivasertib is active in cancers that have lost PTEN, and also fulvestrant can have some activity against ESR1 mutations. So I think there's a lot of reasons to want to consider using fulvestrant and capivasertib, recently approved by the FDA in her case.
So, and we touched base on the ADC. So, actually, this patient received paclitaxel plus pembrolizumab, and the reason was that we were not able to get the liver to perform ER/PR, and they were concerned that it might be ER negative. So we started the patient with paclitaxel pembrolizumab, and Dr.
Yes. So we're showing the initial CT on the top row and then the response below. So in the left column, you see that nodule along the fissure has basically resolved. In the next column, the subcarinal node is also decreased in size. In the third column, the liver mass has decreased. And then finally, all the way on that right, that large right axillary mass is decreased in size.
So fantastic. So I think this particular case highlighted the fact that we can question the diagnosis by genomic data, and also change of the diagnosis for this particular patient opened multiple treatment options for the patients that would not be available if the patient was a GI origin neuroendocrine tumor, and we'll see how the patient responds to any of those, but I think this opened a lot of treatment options for the patient. So let's just go to case number 4. This is a 56-year-old woman with ER-positive, HER2-negative PIK3CA mutant metastatic breast cancer with rapid progression on PI3K inhibitor plus fulvestrant. History goes back to June of 2012 when she had a radical mastectomy axillary dissection, showed a grade 2 ER-positive, PR-positive, HER2-negative disease. The tumor was T2N1. She received OS and tamoxifen. Then she had an abdominal ultrasound that showed a solitary liver lesion suspected for recurrence. Additional imaging didn't show any site of disease outside. The patient had a solitary oligometastatic disease, had a biopsy of the lesion that showed ER-positive, PR-negative, HER2-negative disease. She received first-line palbociclib plus letrozole with good progression-free, progression-free survival. And in March 23, she had a progression. She had a biopsy of that, showed a ER-positive, PR-negative, HER2-positive, HER2-negative disease consistent with what she had before. I'm showing the liver metastases here. I don't think that we need the radiologist. There's a solitary liver metastases here. So, the patient had a liquid biopsy, and the liquid biopsy at the time showed a PIK3CA mutation that was 542K, and the patient received alpelisib. There were also multiple other alterations, including DNMT3A and ATM, that most likely were coming from clonomatosis. So, Dr. Curigliano.
You know, according to the data that we have from SOLAR-1 and BILIVE, this was a patient with a liquid biopsy positive for PI3 kinase. She had a longer exposure to AI plus palbo. So the idea was to propose fulvestrant plus alpelisib, finally. So this is what we did.
So the patient received alpelisib and fulvestrant. She had a very rapid progression, 3 months on alpelisib fulvestrant. You see that there is a progression of the disease in the liver. And the question was, why this patient didn't have a good response? And one issue that was raised was that maybe Dr. Curigliano and colleagues, they thought that maybe cell-free DNA didn't capture the whole landscape of the mutations in this case, and they performed additional testing. Dr. Curigliano, what we see here?
And so we performed an analysis NGS on the tissue biopsy, and we discovered that, okay, the PI3 kinase mutation was confirmed, but there was a P10 deletion. That is the primary mechanism of resistance to alpelisib. So the message for us was the liquid biopsy alone maybe is not reliable to predict the activity of a targeted agent like alpelisib. We need an expanded panel to better understand if there are molecular markers of resistance. And here it's very clear that P10 deletion was the reason why alpelisib and fulvestrant was not so effective in this patient.
So, Dr. Turner, it seems like this patient had multiple.
And then we have an ESR1 mutation also.
Yeah. So this
and the
like
question is whether to use or not elacestrant, since there was a longer exposure to palbo AI, and this is the question for Joyce.
Well, I'd like to hear from Nick with regard to this particular F404V, because you'd be tempted certainly to think about elacestrant for the patient, because there's data that it actually is efficacious in patients with visceral disease compared to standard endocrine therapy physician's choice. So just because she's progressed through alpelisib so quickly, I wouldn't necessarily not treat her with elacestrant. But I don't know if there's any information, Nick, about whether elacestrant inhibits this particular mutation.
Well, elacestrant is active against ESR1 F404 mutations. These aren't mutations that activate the estrogen receptor, but they can cause resistance to fulvestrant because the phenylalanine of F404 is involved in fulvestrant binding to the estrogen receptor. It forms what's called a pi-stacking bond. So if you mutate it, you make fulvestrant less effective, but the oral SERDs are potentially still active. But there's strong reasons to think oral SERDs are not going to be effective in her cancer because, as you've pointed out at the bottom here, she's got an ESR1 fusion. And these are a very important but relatively rare way of activating the estrogen receptor and hormone receptor positive breast cancer. The point being is it makes them completely resistant to all endocrine therapy because you don't have the ligand binding domain, you have the DNA binding domain fused to another protein. And so the estrogen receptor is still activating all of the genes that the estrogen receptor activates, but it doesn't have the ligand binding domain in the fusion. So all of our current endocrine therapies, of course, bind to the ligand binding domain. And so these tumors, we assume, although there's relatively little evidence, we assume they won't respond to endocrine therapy.
So the question is, are all of these fusions activating? And a lot of them are actually not, but as mentioned, the ones that usually lose the LBD domain, but they keep the DNA binding domain, depends on the partner, so on and so forth, that can result in resistance. And the problem here is that they are resistant to all sorts of endocrine therapy that we have, including SERDs, including the current PROTACs that we have, and how we can target them. I'm just provide one of the solutions is just going for translation of ER. This is a trial done by Dr. Rosen, EI4A inhibitor, preventing the translation of the ER. Then it showed that in this trial, the trial is ongoing. We see how the trial goes, but there is good preclinical data that such an approach can help in this type of setting. PTEN loss, a major mechanism of resistance to alpelisib. Dr. Curigliano, can you run us through the data?
You know, this was the original paper of Dejan Duric, and your paper also demonstrating with multiple biopsies on clones resistant that this was the major driver of resistance to alpelisib. So for sure, with a molecular profile like this, you should not give a PI3 kinase inhibitor.
Fantastic. So the tumor also had CDK6 amplification. Tumor had multiple different mechanisms of resistance to endocrine therapy. This is a work that was done by Cheng Li and Dr. Chandra-Lapati from MSK, showing that the CDK6 overexpression and amplifications result in resistance. It's actually a very interesting mechanism for resistance. It's through the trimer of P18, INK protein, cyclin D, and CDK6. And the P18, this blocks the site that the CDK4/6 actually binds, and that by itself, it's a very weak, results in a weak suppression of ATP and prevents the binding of CDK4/6 inhibitor that results in a complete deactivation of the molecule and results in resistance. So we will skip this part for the sake of time, and we'll probably spend a few minutes talking about some of the challenges in the liquid biopsy, which is a highlight of this case. Dr. Curigliano, what do you think about this?
Well, you know, of course, you have technical challenges in detecting fusions on ctDNA-based NGS panels, of course, and sometimes also the copy number alteration may require higher level of detection. That's why in our cases there was absolutely this discordance, because the quality of the sample was not optimal.
Yeah. So there are also some intrinsic and technical issues with the liquid biopsies that we should be aware of. Often for copy number alterations, unless there is a good amount of ctDNA in the blood, the limits of detection for liquid biopsies are not as good as tissue biopsy and tissue sequencing. There are also some of the alterations, such as fusion, so on and so forth, are not captured with these type of liquid biopsy analyses, because sometimes that exonic region is not even included, or intronic region not included in the panel to be captured. So we should be aware, and often, as was done in this case, when there is a discordance or there is a reason that to order more tests, order liquid biopsy and tumor tissue sequencing to understand the cases better. So the MTB recommendation was for the patient to have the ablation of the liver. Dr. Gupta, what do you think about oligometastatic disease and radiation therapy or local therapy?
You know, it's easier in retrospect to say that there may have been a role for, you know, focal therapy for that oligometastatic or oligoprogressive liver lesion, but I think we don't have prospective evidence to know that this is beneficial in all cases. There's actually a randomized trial that was conducted out of MSK, actually, that was looking at SBRT for oligoprogressive, 1 to 3 metastatic lesions. And while there was a benefit in outcome in the lung cancer patients in that study, the breast cancer patients as a whole did not benefit. So there is, and I believe that's in press at Lancet. So there's a need for better selection, and I think what happened here was appropriate, but given that there's local progression, I think considering palliative, focal therapy, whether radiation or thermal ablation or other approaches could be considered.
Fantastic. We had another case, but we are running out of time. So with that, I would like to conclude this session. Thank you so much for participating, and thank you, the panelists, for a fantastic discussion.